Good morning.
Good morning.
All righty. So just kind of wait 1 minute while we get everybody on. Make sure we got everybody. We can get started. Right. All right. So any questions this week for you guys? How did the week go? Guys all should have been on diagnostic imaging and dentistry.
I feel like even when I was in radiology class, I don't know what it is. When you're reading it, you get it. Then you go test on it and you're like, nope, it just like doesn't stick. So any tips on how to remember all that for test like the VTNE?
Yeah. Are there any things in particular that you
Usually like when they ask questions about if it needs to be lighter or darker, do you increase KVP? I don't know why I had the hardest time remembering that.
Yeah. Okay. So we'll definitely go over that stuff.
Okay.
And that stuff is definitely things because I feel like now we have digital that does that for us, right? So for the most part, sometimes we'll have to change it here or there if it's definitely washed out or anything to that nature. But back in the day when we had to do it and do a lot of retakes, because they were too light or too dark, we definitely had to do the math for that. So, but now, our digital radiographs fix it all for us quite a bit. So it has 100% decreased those retakes on that end. Most of our retakes are due to what reason would you say?
Positioning, movement,
Yeah.
I think the problem is they still ask those questions on the VTNE and it's like,
Yeah.
I don't know why I don't get it. I cannot remember it for life.
Yeah.
You can have a little cheat sheet from a
Right.
GP to help us when we do have to adjust it.
Right.
But I
So
still like, I don't know.
does anyone still at their practice not have digital? There are some practices out there that still don't have digital. I have come across them. So that's it.
I don't. Oh, sorry.
Yeah, go ahead.
No, I was just gonna say I don't at the one I work at now, but the one I used to work at, I did.
Yeah.
And we had to go in the developing room and do all that fun stuff.
Yeah. Yeah. So, and that's a big reason why the VTNE still hangs on to those questions is because yes, while a lot of us still have, we do have digital, there are still surprisingly quite a few out there that don't have digital yet. And what happens, if we do have, our digital is just like not working correctly or it's not calibrated correctly or whatever, we do still have to go back to that knowledge base of knowing how to correct our MAS or KVP or anything to that regard. So it is really good to know that knowledge and have the history behind it, to know that stuff. So it is really important to know that. So yes, we will 100% go over that stuff. Anything else kind of really make your way and say, oh my gosh, I need to go over that. Especially radiology, I feel like.
Good morning. Yeah, I had a question in regards to dentistry when the positioning.
Okay.
Maybe just, how sometimes the angle gets me a little confused.
Yeah.
That's one thing that I have a little trouble on.
Yeah. Positioning for radiographs, I'm assuming.
Yeah.
Okay.
Yeah.
Perfect.
Thank you.
Yeah. It can be, yes, 100% a little bit awkward for sure. There's a really good video by, oh gosh, now I'm blanking. Mary Berg, that I posted to, where she goes over that positioning really well and a lot. I don't know how you guys learned it in school. If you were learning bisecting angle versus in parallel, versus now learning it on like degrees. How are you guys learning it in school?
I remember them talking about both.
Okay, good.
Yeah, they did show us both. And maybe that's why sometimes I kind of like get those two confused and the bisecting angle. I don't know.
Yeah,
Yeah.
it's good to understand, and we'll kind of talk about that too. It's good to understand, like, yes, we're doing this on bisecting angle, but it is bisecting angle, yet we're gonna do that bisecting angle at a little bit less of a degree than, that 45-degree angle, like that we do the head on, like our incisors. Like incisor, you're definitely doing that like 45-degree bisecting angle or whatever, or like that straight on angle, where some of these, the molars, we're gonna do those at a certain degree angle that might be a little bit different. So Mary Berg's video is really good because she gives you like kind of some tips on how to do those angles and things that she's learned while she's done them in practice too, so that you're not just kind of utilizing it straight out of a textbook as well. And that is something that every head is very different, right? Like we look at maybe a Doberman head differently than a bulldog head. So kind of lining animals up a little bit differently is going to be essential. So she'll give you some tips on like, making an L on their face and then aiming that beam a little bit different when you are, doing a canine tooth and stuff. So it can be kind of helpful in those cases. So definitely review that video too, when we talk about doing those different teeth. And then same thing with like the back molars, like going high and through the eye and stuff to try to remember those things. So I'll definitely show you that video. So how about like, did you guys go over ultrasound stuff as well, or to some degree?
We haven't went over ultrasounds in school yet at all, so
Okay.
that's like new to me.
Okay. And just like how images, the color that they show up is going to be different than obviously on radiographs, right? Like what you see on a radiograph of fluid on a radiograph is going to be different than what you see on an ultrasound, correct? Like what color would appear if you saw fluid on a radiograph?
Isn't it like a circle, like there's an outline of white?
Good, right? And then if you saw fluid on an ultrasound, right, what would fluid appear like on an ultrasound?
It's black.
It's black, right? Good. And so how do we term that on an ultrasound? How is that termed?
Oh, I was thinking the ultrasound. So ANEC, I can't say ANO.
Yeah. And echoic. Good.
Thank you.
Yeah. Good. So meaning that it is not bouncing off any waves, right? Sound waves. So it's no echo coming back, right?
Yeah, and no, nothing.
Yeah.
Yeah.
Very good. So if there's if it's slightly like a gray compared to a white color, how is that termed?
Is it hypoechoic?
Good. Yeah.
I thought there was one in the middle of there, but
Yeah, so you can have hypoechoic, and then when you, so even if you are comparing even a black to the gray, you can call that still, it's hypoechoic to, you know, that too, like how you compare it. I mean, you could still say it's anechoic as well, but it's still hypoechoic to something else. So either or is fine. It's just hypoechoic to the other. And then the white is going to be hyperechoic to the other, right?
correct.
Good. So
Just the three terms then?
yeah.
Okay. For some reason I thought there was another one, but okay.
Not that I
No,
can-
you're really right. I'm
okay.
just overthinking it.
Yeah. So it's just the way that we describe one another, right? So as you're describing something, like if you're talking about the spleen, you know, the bladder or whatever, that's just the way that you're going to describe those tissues to differentiate what they all look like, right? So, or if you have, you know, something that's in the bladder, right? So say you have some mineralization in the bladder, you could say there's some hyperechoic debris in the bladder or something. So it's just a way of describing something that you see on the ultrasound. So those are some key things that you would be able to talk about from ultrasound. And then when we talk about radiograph exposure to people, so say that we have someone who's pregnant, and what is the most critical time, you know, that someone should be really, really careful. Like granted, we should all be careful if we are pregnant, but what is the most critical time that they should be careful from radiation exposure?
The first trimester.
The first trimester, good. And why is that?
That's when like the baby is developing the most.
Good. That's definitely when they're really developing the most. There's a lot of cells like definitely reproducing at that time and growing and stuff. And so that is a very important trimester that they should be most careful during that time. And so definitely limiting as much radiation exposure as possible. And so so this might be a trick question, is there a protocol that is in place for radiation exposure for pregnant women?
It's like up to your practice and what you decide.
Okay.
I don't know. That's what I thought in like vet tech school. I thought I learned that.
Ooh.
I don't know if there's like a protocol necessarily, but our instructor was pregnant last year and she
Okay.
teaches our radiology class. So she had to wear 2 vests. She had to keep her dosimeter on the top, and then she had another one on the second one.
Good, good. Very good. So it actually isn't up to the practice on what they decide on it. They have to actually provide you with the appropriate equipment if you and your doctor decide that you still want to continue to take radiographs. So it's actually up to you and your doctor on that. And so there has for many, many years, where they say, like, if you're pregnant, you can't take radiographs or whatever. I mean, of course, many women choose not to take radiographs and, just to be safe, and that's totally fine. You don't have to. But there's a lot of practices that will say, like, no, you're not going to take radiographs, and people comply. But if people choose that they want to, then it's the practice's responsibility to get them the safe equipment to do so, right? That's OSHA's regulation, just like it's OSHA regulation for them to give you the safe equipment when you're not pregnant, right?
Mhm.
So you are absolutely right. She probably didn't have to wear 2 gowns, but it doesn't hurt to wear 2 gowns. But she's absolutely right to wear her dosimeter badge up on top. And then there's a fetal dosimeter badge that they would wear by where the fetus is. And what they do is the fetal dosimeter badge will be submitted every month, and rather than every 3 months for us. And then that fetal badge comes back, and we make sure that those are within normal ranges. Now, the normal range is much smaller than what our normal range would be for our yearly range. So that's the biggest thing that we have to be careful of, is that, a person who's pregnant cannot take nearly as many radiographs while they're pregnant as what we can normally take. So as long as they can stay within that normal range, then that's completely fine.
I always laughed because at our big hospital, that's how we knew someone was pregnant, because we'd say, "We want to have the Xrays," and they would quietly walk away or just smile at us, and we're like, "Okay, never mind, not you." Can't keep it a secret for very long.
Yeah. And I mean, it's totally up to that individual person on what they would prefer to do. I mean, same with,
We tried
people,
not to. It looked like anybody that was pregnant, we just tried not to use them.
yeah,
So many other people around, it's like not worth the risk.
right. And I think that it just depends too on your practice. Like if you work at a really large practice that you can really avoid it, then that's totally great. There, of course, are so many other practices where you might only have like, 1 doctor and maybe 2 other technicians, or maybe just you and the doctor, where that can make it really difficult. And so as long as you can keep that person safe throughout it, then, and you might not take that many radiographs anyway, then that might be okay, you know, and you feel comfortable with it. So I think that now that we all kind of know, okay, we have the freedom now to say, hey, with my doctor's help and saying that I can choose, we can make this safe and we can have, you know, all these safety measures in place, that we don't have our employers saying that we can't do this, like it's an OSHA guideline. So so and you know, if it's safe when we are not pregnant and we have these other safety measures and we know how safe it should be when, you know, we are pregnant, then it should really be safe. So how should we lean off our ultrasound probe?
You said clean off.
Yeah.
They use white, like washcloths that have blue pearl.
Okay.
But the one probe, they put a like rubber glove type thing on the end.
Okay.
Because the radiologist is very particular, but we also have specialists that are particular. That's all I've ever seen, I guess.
Yeah. Do you clean it with like with alcohol?
Well, they've used alcohol in the stomach, so I guess you could.
Do you see your radiologist use alcohol?
That's a good question. Now that I think about it, I don't know. I always see them white. Well, we usually they have their little workers, so they usually do it all. But we're leaving the room usually by then.
Yeah. Usually you'll see like ER use alcohol, right? But the alcohol actually will ruin the rubber coating on that probe and break down the crystals on that probe. So that's why they recommend actually using the nice gel.
It's
So,
sorry.
yeah.
It's a you said that they use a gel. Is a gel for better transmission or
Yeah. Yeah, to get that.
okay, not for because I've seen them use wipes, like special wipes that they have for
Yeah, you can use that too.
okay.
Mhm. Yeah. So, and they can even have like the spray too. They have like a spray as well. But it's not an alcohol based spray. But yeah, for some reason we can't get some of our doctors off of the alcohol. So yeah, there's a lot of radiologists that will give an like they'll have an ER ultrasound probe. And then the radiologist is like, this is my probe, you can't touch it because my baby. Because they don't.
Does the alcohol like dry it out?
Yeah, and then it'll break down that probe and it'll crack and all of that jazz. And it ruins the probe. And of course, you know, those probes are really expensive. And then when it breaks those probes, you start seeing like, you'll start seeing kind of these starburst types of things on the ultrasound that aren't really there. You won't get like a really good image on your ultrasound itself. And yeah, you're just not getting a really good view of your animal when you are looking. So you're not getting great detail and things. So the probe then eventually just needs to be replaced. So essentially what you have to do is, yeah, you just wipe it with glucocorticoid based disinfectant. So just a nice little disinfectant to clean it off. But no alcohol. So what does the acronym ALARA stand for?
As low as reasonably acceptable, or like there's something else I can't remember. I always forget the last part.
I think
Achievable.
it's achievable.
There you go.
Yeah. Good. As low as reasonably achievable. Very good. So what does that mean?
To keep your radiation exposure as little as you can achieve.
Okay. So how do we do that?
Time, distance, and shielding.
Ooh, time, distance, and shielding. Okay, so let's see. Time, distance, and shielding. All right. So what does that mean when it comes to time?
You want to decrease the amount of time it takes you to take an X-ray. So like a lot of it has to do, if you can just take one, then only take one. Don't take retakes.
Yeah, decrease your amount of retakes, right? So retakes are terrible. Retake. Right? How many of you guys have to take so many retakes?
We have a relief vet that doesn't like any x-rays we take. She's ridiculous.
Yeah. And so that's a good time to be like, even beforehand, to say, okay, like we already know that this lady doesn't like anything that we like. So let's game plan before and say, please tell me exactly what you would like us to take. So that we won't have to take as many as possible.
Yeah, we try that.
Oh, okay. Okay.
We do try that, especially once we learn, like she's been with us for almost a year now. So once we learned from the beginning, but it's still never straight enough, or, you know, that kind of thing, especially on VDs.
Yeah.
Even though we use the trough,
Yeah.
and that really helps. But yeah, I know the girls the other day had to take 5 extra X-rays than they were supposed to. And I wasn't there that day, but this is them telling me this. But yeah, I mean, to me, because I'm the OSHA safety coordinator, I was like, oh my God, stop.
Yeah.
Yeah.
And then it comes down to like, was one, the patient not being cooperative? And if that's the case, then at some point, then that's where you guys speak up and say, okay, if we can't get this patient straight enough for you, then we need to do some other intervention. Like, we can't get this patient straight enough after the 3rd time, then you are going to have to, as the doctor here, are going to need to give us some type of additional medication, like full on sedation, so that we can get this patient super, super straight, so that we can get exactly the image that you want, or you're going to have to be okay with this. Or she's gonna have to jump in and do the radiograph for you guys so that she can get it as straight as she really wants it. But
Yeah. Most of the time her patients are not sedated because she's always running behind and we never have time.
yeah,
But yeah, that's a good idea, suggesting just, can we leave him here and then sedate him over the lunch hour or whatever it is.
yeah.
Mm.
And then that's gonna be where, you know, other owners are gonna start getting upset, and you guys need to also take your lunches, so it can't be about like over the lunch hour either.
Yeah, our lunches are 2 hours long. So
Oh, okay.
theoretically we could, at least the
Yeah.
doctor lunches are 2 hours long.
Yeah,
Ours are never, but
yeah,
yeah, that's what we call our lunch break is, noon to 2.
yeah. But at least if you guys have them sedate enough, like the decrease of retakes too would be so much better. Like, of course, I don't know, like how the patient was behaving or whatever, but if he wasn't straight enough, like that's 5 radiographs just to get a VD that's that completely straight is a lot to then say like, okay, we need to do something different here. So like this is not working.
I agree.
So yes, retakes 100% is really, really important. And so what about distance?
Increase the distance between you and the X-ray machine, or like the main like beam, scatter radiation, like anything like that.
Yes, good. So decrease distance between you and beam and scatter. Can't spell scatter, guys. And scatter. So how do we do that?
Hopefully your patient is maybe sedated. I know that sometimes it doesn't always work out like that, but if you can use like props or like restraint things like sandbags, so then you don't have to be there to hold the patient. You can step away or even step behind, like maybe like a wetted shield or something like that.
Wonderful. Yeah. So if we have some sort of hands-free aspects, right? So if we're using any types of hands-free, would be great. If anyone has been trying to do some sort of hands-free, that's awesome. At least whenever you can. Right? So there are probably some opportunities where we can use hands-free, or if you have like one person in the room because your patient is, somewhat sedate, so you can have one person in there. You probably don't need 2 people, right, to expose. So you can just have maybe one person on that end of it, or use more sandbags or tape on your patient or whatever. Distance wise too, so distancing yourself from that scatter. So if you can use more like ropes or which I feel like we used to do this a lot more, spoons, that type of stuff, so that you don't have your hand as near to that patient as you could, so you can move your hands back from that patient and move yourself back a little bit further. That distance means so much more, right? So you're still in the room, yes, you still have your gowns on, yes, and all of that, but you're so much further back from the primary beam and that scatter that it will be so much more beneficial, right? So the more that you can add to your patient, the better. How many of you guys have those like blue trough things at your practice? Those dark blue troughs?
Yes.
Yeah?
Yep.
How many of you actually use that Velcro that's on the ends of those blue troughs? No.
Negative.
The black-
Sometimes, yeah, sometimes.
Sometimes?
Yeah.
Do you guys know what the dart or that Velcro is supposed to be used for?
Like holding the legs.
Yeah, absolutely. So that dark or that Velcro that's on that trough is there so that you can Velcro those legs to the trough to help you aid in holding that patient. So it gives you an opportunity to at least assist you so that you can wear your gloves or, just hold the patient a little bit better. And so I don't think that people like actually teach you many times of how to actually use some of the devices that we actually have in 100% wonderful way. So, utilize those things as best as you possibly can. It's amazing to actually use those for cats and for some of these squirmy dogs to actually use that Velcro appropriately. And then actually put your gloves on. And even if you would just have to hold their legs a little bit with the gloves, it actually works really well. And then what's another part of distance that now that we have digital, we really suck at doing? Because people say, we can just do this after.
Marking the X-rays.
Mhm.
Oh, yes, but it's not distance, but you're right. We can mark the X-rays after.
Sorry. Yeah.
I'm sorry, you said the question about the distance. What was it?
I said we really suck at doing it because we can always do it after. People say we can always do this afterwards with digital, but it's collimation.
Right.
So this is part of distance too. The more we can collimate down on our patient, the more it focuses in on what the primary beam is going to shoot. And so we decrease the amount of that X-ray that's going to actually come down on that patient, right? And there's going to then be less scatter that's coming out too. If we don't collimate, it's going to open up that beam as much as possible. And then we're going to have more scatter coming out. So it has nothing to do with, oh, we're just going to collimate later. It has a lot to do with the fact that we're just letting it all out and we're going to have more of that radiation coming out at us and scattering out too. So, sure, you're absolutely right. We can, just like on our phones, we can later on, collimate our picture on our phone too, right? We just use that term, but we can cut things down on our phones too. But in this case, it's just a safety reason why too. So cut it down right away. And if we need to cut it down a little bit more, afterwards on the computer, that's fine. But collimate first right away. And yes, 100%, don't forget your marker.
So here's a question.
Yeah.
For a cat, I have a doctor that likes to take full body X-ray.
Yeah.
Is it safer to do a full body X-ray and just do one shot, or collimate it down and do a thorax and then an abdomen? Which one?
So your radiologist would say that they would prefer to have 2 radiographs because of detail wise. I don't know what would end up being safer.
Okay, so so most likely they're probably equal in the amount of scatter radiation you're getting.
I would assume so. I don't know. But
Okay.
yeah, I would say that like I mean, I can see the detail wise, like I've seen the difference too. Like you're definitely missed a lot of really important detail, you know. Yeah.
Okay, I was just curious.
Yeah, but that's a good question because I see a lot of catograms done. But I also can, yeah. I know that sometimes they're like, oh, just do a catogram because we're here, and they don't maybe they really only are there for like the abdomen, and they're like, let's just get the chest in there anyway, you know?
Yeah, she does that a lot.
Okay, shielding. So what is our shielding? What does that mean?
So like lead line barriers, aprons, gloves, goggles,
Ooh, good.
stuff like that.
Aprons, gloves, goggles,
Thyroid shield.
thyroid. Shield. Oh God.
I have a lot of tech friends that don't put that thyroid shield on. And it stresses me out. My sister had thyroid cancer, and I know other people, and they're like, "Why don't you just put it on?"
Yep.
Roll their eyes at me.
Yeah, well, how many of you guys wear gloves then?
I do, and they're anal. They laugh at me, but I told them it's because I'm old and I'm not dying of cancer.
Yeah.
And Blue Pearl has that scary hand hung on the wall.
Yeah.
It scares the crap out of me.
Yep. So I think I read a study that said it was like 95%, which I think is still probably not high enough, but 95% of people in the veterinary field don't wear their gloves because they are not practical. I think it probably is closer to like 98%, but yeah. So 95% of people in the veterinary field don't wear their gloves because they're not practical. And I think that again, if we've gotten better with people wearing the thyroid shield over the years, right? So when I first started in the field, people did not wear their thyroid shield at all. Like it was terrible. And then we became very aware of people getting thyroid cancer, getting huge lumps on their necks and just horrible, horrible things. And people were like, okay, we are going to wear a thyroid shield. This is becoming very apparent. We must do this. So we got much better and people were wearing their thyroid shield, and we still struggled with wearing gloves. So the thing is, again, it's an OSHA requirement that we have our places of employment provide us with appropriate apparel or things that are needed for our jobs. And the unfortunate thing is that they provide us with, the essentials. You might have your aprons and things that you need, but they might be things that are like, I don't know, 30, 40 years old, right? So it's important for us to examine these things and say, look, these are not practical. These are things that are not useful to us. And if we're not able to use them, if we're not using them, we're putting ourselves in danger. That's on us. And so now we need to say, look, I cannot use this. I need to have something that I can use to keep myself safe. So there are gloves out there that are actually decent to use, that you can use to keep yourself safe. So I personally really like some of the other things that are out there that you can actually like machine wash, because let's face it, some of the aprons out there are disgusting after you have had to use the same apron after person for 20 years. And the lead aprons, you can't like put it in a washer and dryer. So how do you wash them after 20 years of like people's sweat and stuff? So there's a company named Blocksar. It's spelled with an R at the end. Looks like that. Anyone recognize Blocksar as a name? It's not a heavy material. It's not made out of lead either. It's made out of a chemical, however, that is resistant to radiation. And so why it's kind of cool is that you can actually put in a washer and dryer and wash all of that material. So so they have gloves, aprons, and thyroid protection too. And then the cool part is that it's super pliable. So like the gloves within itself, you can actually use and hold like cats, and dogs and all of that. And so I really like those a lot more than trying to hold animals that way. So a lot of hospitals they started getting a lot of the gloves that way first and then changing over their aprons and thyroid shields. So it's, to me, a really good investment. Now, how often do you guys check your aprons, gloves, thyroid shields and stuff for any type of tears, holes, anything like that?
I check them every 6 months.
Good. Anybody else?
The GP I worked at, I had to write a paper. I think she does the same as Jennifer. She has it all logged out.
Good.
Actually, I want to say she even does it. Maybe this is awesome. I don't remember. I wrote the paper, but yeah, they're very good, but they're AHA approved, so they have to.
Yeah.
But I didn't realize that is a dosimeter. Is that how you say it? They
Dosimeter.
have to keep that stuff on for 30 years. They got to keep that information. I had no idea.
For 30 years.
Yeah, I was told 30 years because people can come back and say, I have cancer and they have to see it or something.
Oh.
So they have it like really organized binder for 30 years. But this clinic's been around for 40 plus years. So
Okay.
yeah, it was crazy.
Interesting.
Yeah. I had to write a paper for the Penn Foster, skills.
Huh. Interesting. I'm sure they could transfer that information somehow. I'm surprised that they keep the papers. Interesting. That's weird.
She may have it electronically, but what she showed me was a
That she
binder
keeps
that they
it.
have. Yeah, but it's a very organized binder. She has like 2 binders. She's in charge of it all.
Wow.
Yeah.
Interesting. So yes, so like in human medicine, they actually have to check theirs at least once a year. But in veterinary medicine, it is recommended to check it at least every 6 months, especially since we are utilizing ours so much more frequently, and we are like in there and we crumple up our stuff so much more and throw it on a table a lot of times, and creasing the lead aprons and stuff like that too. So it is just a better idea to have them checked every 6 months to make sure. Lead within itself does not do well to fold or do any of that type of thing. So it really should always lay flat or hang up. And so if you guys ever like fold it up on a table or not lay it flat, they can crease or crack. So that's why it's really important to check those lead gowns and thyroid shields and stuff. So if you have a tiny little tear in there, if you have a little tiny pin prick hole in there, you have to replace the whole thing. So that's also a really nice thing about the Black Star thing too. Not that I'm like product placing or whatever. I don't get any money from them, but it is nice with them too that you can crumple it up, you could toss it, fold it, whatever, that it will not like actually break or anything to that matter. So you can manipulate it and it's totally fine. So now goggles, someone mentioned goggles, which I am surprised but happy about. Why are goggles on this list? Or who has goggles? Or glasses? You can have
Yeah,
glasses.
we use them too.
Good.
We use them as well, or at least I do. Not everybody in my clinic will wear them, but we do have them.
Good. Are you guys AHA accredited?
Yes.
No,
Awesome. So I'll give you guys a little side note. This was just written in as an AHA standard a couple years ago. I wrote that as a standard.
Oh, that's awesome.
Yeah. Yep, when I worked there. So a big reason why that was written in was because our eyes are actually extremely sensitive. And there was a lot of research done that our eyes were found to be even more sensitive than we realized. And so if we're taking radiographs for as long as we are in the veterinary field, you know, we start when we're really young and we're going to be taking radiographs for a long period of time. We're not protecting our eyes at all, but we're protecting the rest of our body, right? There's been shown proof that we can end up getting cataracts from the radiograph exposure that we take. And so we really should be protecting our eyes as well. And protecting our eyes does not mean turning our head and closing our eyes. Like that's not going to help, right? Because scatter radiation goes everywhere. So by wearing lead-lined goggles or glasses or anything, that's definitely going to help. And so I was like, there are cute goggles out there or glasses out there you can get. They're all different colors, you know, go for it. And, you know, some are just a couple $100. Definitely wear them and protect your eyes. I mean, that's how we see the world. You don't want to lose it. So that was added to our list. So, yeah. Another part that we, of course, part of our shielding too that people will add to that is our dosimeter badge, right? So somebody brought that up too. It's not, of course, part of that lead lined, but it is something that we monitor of how much radiation we are exposed to, right? So how often do we monitor our dosimeter badges?
Monthly?
Okay.
Or, I mean, well, we
Good
have to
guess.
send it in every 3 months, I think.
Oh, good. So we send it in every 3 months. Very good. Yes. And so there are a lot of different ones out there, right? So some people send theirs in. Do any of you guys have other dosimeter badges where you don't send them in? There are some out there that you can actually keep in your practice and they're like read via like USB drive. They're a little fancier and a little bit more expensive. No? Okay. So most people have the ones you send in and you get new ones sent to you kind of thing. So so when we talk about how much we can be exposed to right? How much radiation can we be exposed to for radiographs?
I'm trying to recall. There was I don't remember the measurement, but it was like 5
Good.
per year or something like that.
Yeah.
But I don't remember the measurement.
Yeah, so you're probably thinking of 5 rem.
That.
Yeah. Or if you think of it could be 5,000 millirem is another way of looking at it too.
You said that was total a year?
Yep.
Okay.
Put that. So then if we're comparing, so this is just the, adult. Okay. If we are comparing, remember we talked about pregnant individual? All right. If we're talking about a pregnant individual, they can receive 100 millirem. Ooh, I can't. Ow. Millirem in a year with being pregnant. Okay, so once they're not pregnant anymore, it goes back to their adult, whatnot. Or 50 millirem per month. So that means that, like, say that they got 50 millirem in that month, in 1 month, they need to be really careful because then they then only have 50 millirem left for the rest of that year. Because then they're going to be maxed out for their pregnancy. Does that make sense? So they have a total of 100 that they can utilize while they're pregnant.
So does that only count for like the 9 months you're pregnant? And
Yeah,
then like once you have the baby, then it just goes back to the normal 5?
Yeah. So again, you don't have a lot of wiggle room, right?
No, so then if they're checking their dosimetry badge and like in 3 months, every 3 months would they just have to, I guess, make sure that they're not taking a
oh,
lot of
So
right?
they're they're checking the fetal dosimeter badge every month.
Okay.
Yeah.
Thank
Yeah. So it from my understanding, from what individuals have said, this is roughly about 250 radiographs. That they can take total. So again, if you work at a general practice where you are just needed here and there to take some radiographs, sure, that's great. But if you're like working in a specialty that's taking radiographs all the time and stuff, like, and you have a lot of people to take radiographs, you might not be that helpful anyway to be taking them because you're going to max out really quick, right? So. Plus you have to worry about too, like all these other factors. You're turning animals on their backs and like, are you going to get kicked and all this other stuff too. So there's just a lot. When we were developing radiographs back in the day, I was the best at developing radiographs when I was pregnant, but now you don't have to do that anymore. So I'd always be like, I'll volunteer to do that part. Don't worry, guys. All right. So let's talk, we were talking about earlier, the MAS, KVP, how do we determine when it's too light, too dark, all of that jazz, right? Okay, so MAS, when we talk about MAS, what does MAS refer to?
Milliamperage per second.
Okay, so what does that mean when we are talking about that in a radiograph?
Quantity.
I'm sorry, you said quantity?
Yeah.
Okay. So a quantity of what in amount of what?
Electrons being
Electrons
boiled off.
in the amount of, what's this part?
Oh, seconds.
Okay, so time, right? So you're right, yes. The amount that we are pushing out in the amount of time, right? So essentially it's like how much time we're exerting all of that out. Yes?
Yes.
Okay. So it is how much time of that exposure is happening. Okay. So KVP, So I always like underline these guys so that you guys know what that means. So seconds is time, right, of exposure. And then P means what?
The power.
Ooh, good. Yeah. I always call it penetration, but power, yeah, power. So it's penetrating the tissue of what we have, right? So the whether it is our patient's like actual body, or if it is, you know, the abdomen or the chest, or if it's their leg or whatever. But yeah, I like power. That's good. So power or penetration of patient. Okay. So that's how you can determine like which one we might need to change. Okay. So if we have our radiograph, my wonderful drawings of things. So here's our patient. I don't know what it is right here because I just made up something. And say we have, you know, our patient here is too dark. Okay. And then in the background here, our background is normally what? It's going to be a dark color, right? Well, hopefully, right? It's usually dark in the background. We like to think of our radiograph in a toast type of way. Okay. So if you guys make toast at home and your toast is too dark, how do you make a lighter toast? What are you going to do to make your toast lighter?
Go down on the number.
Yeah, you're going to go down on the number. Now, which one are you going to turn down?
Good
This-
time.
So this is our patient, right? This one is the one that's too dark. This one's fine because it's dark. So we're good. I should say that this one's normal. This one's normal because we want it to be okay. So that's normal. This one's too dark. So which one are we
Why do
gonna?
we want to, Bailey?
The KVP.
Yeah, so we would turn down our KVP because our patient is too dark. Okay. So when we turn on our KVP, we always change the KVP, whether it is up or down 10 to 15%. That's like the rule. If we want to change our MAS, we would change it up or down 30 to 50%. That's the rule for that guy. Okay. So it always just depends for you guys. Like if it's really, really dark, then you could always go 15%. Or if it's just a little bit dark, start with 10% and then, you know, kind of go from there. So yeah, if it's really dark, maybe you do 15%. If it's really not that dark, 10. If you're seeing that both of these are dark, you know, so like say this was really dark as well, you could say, okay, well, maybe this was really dark too. We could change the MAS 30%, and then maybe this as well, maybe this as well, 10% and see what happens, or maybe the MAS because it maybe got overexposed as well. But in this case, we'll just say that we're going to change we're just going to do our KVP first. Oh, normal. All right. So let's say that we're going to say this is light And then this is going to be light. All right. So if the background is really, really light, okay, that means that potentially we didn't have enough time of exposure, right? We didn't have enough coming out. And so we might not have been able to have enough really to get coming to our patient. So we could at least start with the time of exposure and see what happens. We could also, right, increase our KVP too if we really needed to. But we 100% have to start with the MAS, right? Because that background is so super light, right?
I think what confuses people, which I know it confuses me, when you're looking at an X-ray, like the idea of what's happening with, you know, the beam or the electrons that are coming to the image or to the patient, right? It hits the patient and it hits also, I guess, the background.
Yeah.
So the idea is supposedly to make the whole image dark, right? But
Yeah.
if there's a patient there, it hits the patient and that turns white, right? It should turn white. Is that, I guess, like the idea of what's
So-
going on? That's what sometimes messes,
So
confuses.
you have this being dark and this being light.
And I think that whole thing kind of confuses when KVP and MAS starts coming
Getting
into
weird.
play.
So if you have this being dark and this being light, this means that this can be completely dark and fine, right? Your MAS could be completely fine. And if this is really light, then what are you going to change?
The time, right? The MAS.
So if you have your patient is really, really light, so it is not penetrating through your patient at all. Your MAS is fine here.
Oh, right. The power to penetrate through, right?
Yep.
The KVP.
Yeah. So what would you do with your KVP here? Would you increase it?
Increase it.
Yeah.
Because you need to darken the toast right here, right? You need to
Right.
darken the toast of your patient.
Right.
Because your toast is already perfect for the background here. Because you want that to be dark.
You know, adding that P and thinking penetration does help a ton, because sometimes I'm with Anna, you stare at it, you're like, which one am I changing? But if you're saying if the background is a pretty decent color, but our image of the animal isn't dark enough, you're just not penetrating enough.
Yeah.
Good way to think about it. That makes a lot more sense to me, because I like sometimes just stare at it like I don't know what to do. But
Yeah,
that
'cause
makes more
you
sense
have-
to me.
You have two different toasts here, right?
Yeah.
So you have to think of the toast of the background and the toast of your patient.
Okay.
So as long as your toast here, like you want dark toast here,
Yep.
okay, and then you want a pretty even toast here, right?
Yeah.
So you want to
Helps.
make, yeah.
Yeah, that makes more sense. The width, but putting the P equals penetration instantly makes more sense to me. That makes sense.
We learned in school, we called KVP our penetrating power.
Oh, good.
And so that's how she told us to
Good.
relate it.
What school did you go to? I need to reach out to that teacher. Say we have the same mind.
NICC, her name's Kelly.
Oh, okay. I'm like, I need to tell her that we have the same brain, which is scary. I will say probably every single like old technician has referred to our radiographs as toast. So anyone who's done radiographs as like, some sort of non-digital. So I don't know why. It just makes sense that way. Digital is great for so many wonderful ways, but they ruined our toast, man.
For the VTNE, are we gonna have to figure out like non-digital radiology, figuring out the KVP and MAS, all that kind of stuff?
They might get you, they might say like some sort of question on like this. They might say, if you're something to the factor of like your patient's gosh, on a radiograph your patient image, the image of your patient is very light in color. How would you fix this?
Okay.
Okay,
but I won't have to make out, like in class we had to make out tables,
oh
you
yeah,
know, and I don't have to worry about that, right?
not
Because
that
that took
I'm
forever.
yeah, no. I mean, that would take you a zillion years. So
Yeah. Okay.
no, more critical thinking, practical end of things. Yeah.
Okay.
Yeah. Or again, like just knowing this, and this factor of how would you fix this? And they would say, your KVP started at 77. Okay. And your, so KVP is 77. Okay. And your patient is too light. How would you fix this? All right. So they give you A, B, C, and D, and they are like, oh, they pick 70, 84, 97, and 106. Okay. So you'd have to pick out of those. And so choose the best answer.
And the patient is too light and you're 77, then you use that 10 to 15%, right?
Yep. So again,
The 80 before be about 15%.
so yeah, so then you get to do your math problem, right? So you're gonna say, okay, so what's 10% of 77?
Seven point seven.
I'm sorry.
7.7. We both said 7.7.
Oh, 7.7. Okay.
Yeah.
7.7. And then what is 15%?
11.55.
7.55. Okay. So then you add 77 to both of these. And what do you get?
84.7 for the first one.
Okay.
And 88.5 5.5 for the second one.
All right. So what would be your answer?
84.
Good. I mean, typically I probably would pick 85, like if I were doing it in practice, right? But I just did that on the top of my head. So, but on the VTNE, right? It's never pick the right answer. It's pick the best answer, right?
Oh, is that because the VTNE is by points, not by correct, right?
Well, it's a VTNE, right? I
Oh, okay.
mean,
Yeah.
I mean, is any test ever 100% like, yeah, I would do that 100% in practice, you know, or whatever. It's really like some of the questions are like, I don't know. But it's pick the best answer that you have, right? So yeah, you have to pick the best answer that you're given. So yeah, like if you have a decimal place or whatever, it's really choose the best answer. So, and true, like you're gonna get caught up in something and then you're gonna sit there and just like ponder for minutes and minutes. You don't have time for that. So just pick the best answer. So yeah, that's how you would do that. So same thing with MAS. So say like your MAS here, like if we're picking something that's too dark, and I'm just saying it was too dark here. So your MAS would be time-wise, let's say it was MAS here is 1. I'm just, oh, I don't know. What should our MAS be? Um, 1/60th. Um,
Can you repeat what the question was?
oh yeah. So, sorry, I'm just gonna get rid of this. So if okay. So if we had our MAS and it was too dark, okay? And let's say that our MAS was, what should our MAS be? I don't know, maybe 1/60th. Let's make it that. And we are going to, so we want to, so our answer would be, let's see. Oh, okay. So out of these, what would we change our MAS to? If it's too dark.
1/40th? If we changed it at 30%? No?
I made this. Oh, I made this have two answers. This is why I shouldn't do things. Let me change this.
Oh, so you're saying if it was
I have two answers.
30th?
You can leave it like this, it's fine. See, this is why I shouldn't write VTNE problems on the fly. We can leave that and so I'll leave it like that. So it could have two answers here. So yeah, you chose 1/40th, right?
Yeah, if we went down 30%.
Good.
And if you did 0.5%, would it be the 130?
Yeah, so if we did the 50%, it would be 130 because you just
Half it.
put that in half.
Yeah.
30% would have been like,
42, I think.
yeah,
Mm.
42. But, if you just went a little tiny bit more, that totally would work too. Just make it a little simpler. Because I'm pretty sure like on your machine, it would not do 1/42nd percent or 1/42nd or whatever. So you can totally do either or actually. So in practical setting, these two would absolutely work. So this one would actually give you for time exposure, right? Probably a little bit, more time or less time exposure?
Less time. 'Cause
Yeah.
I'm going down
Yep.
3%.
Yeah.
I'm sorry, Beth, and you said that the image that the patient or the background was darker?
Correct.
Okay, so both the patient too, I'm sorry. I'm getting confused a little bit.
No, you're okay. Yeah, it was darker. It was too dark.
Yeah, so the time is I guess if it's too dark, the time is I guess the time was too long. So we need to lower it, right? Because it exposed it like overexposed. Is that what happened?
Correct. That background is too overexposed.
Oh, okay.
Mhm.
Quick question. So for the KV, we're going to either increase or decrease by 15 or 10%. And then MA, like in seconds, is going to be by 30 and 50%.
Correct.
Okay.
Yeah. Yeah, so your MAS is always in that 1 over something, right? Your MA is that you guys see, like if you're changing MA is in like your hundreds, right? So if you're changing MA, that's in hundreds. If it doesn't include the S, it's in hundreds. But with an S, it has 1 over that whatever number it is because it's a second. The fraction of a second. That's why when you guys take your radiograph, it is a very quick exposure. It's very fractional second that you expose.
So if it's just MA, is there a certain like percent that you do like go up by if it doesn't have the seconds on it?
Wait, can you repeat that?
Yeah, sorry. That's kind of worded funny. So if for the MAs per like second or like the MA with the S on it,
Yep.
so increase or decrease by 30 or 50%, is it
Yep.
the same for just MA or is it a different thing?
You could still technically do that 30 to 50%, I guess. But you should still be looking at the MAS per se when you're doing those time exposures.
Okay, thank you.
Yeah, of course.
So like with our I don't know, like with our X-ray machine, whenever we are setting it up or whatever, the MAS, it says it'll be like 3.5 or something like that.
Yeah.
So how would you like
That
would you just do
yeah. So the 3 point, yeah. So that does its own, great question. So that actually does its own calculated form too. So if your MAS is, thank you for that. So, so say it is it's MAS, right? So say it is
Yes.
2.4, right? Same thing. So if it is, oh goodness gracious. So say it is you had your background too dark here, and your MAS here is 2.4. You are going to take that as too dark, and you are going to decrease it, right? Because it's too dark, and change that by 30%. So we're going to decrease that by 30%. So what's 30% of 2.4?
1.68.
2.4 times. Oh, you already did all that math. Okay. 0.72 is 30%, right?
Oh, sorry. Yeah.
I'm like, you did all of that math.
all the way
Right.
around.
No, you're okay. So 30% is the 0.72, and then we are going to subtract it, and then that's 1.68. So that's the total that you'll do. So at least 30% is that you'll go back to your machine and enter in or go down to the 1.68 or 1.7 and do at least that much on your machine. Sorry, my dog lose their mind. 50% would be 1.2. So you just take your original 2.4 and do 1.2. So if you go and take your radiograph and it's still like really, really dark, you can then go to 1.2, or if you're like, no, this is super dark, we just need to go to the 1.2, you can go to 1.2. So imagine taking like dental radiographs, right? And on dental radiographs, you still have a KVP and you still have an MAS, okay? And your MA and all of that. And hey, they come out just as terrible in a sense. You still follow the same rules, right? The cool part is that dental radiographs, there's you can really maneuver things where you don't have to change a lot. Like you can press buttons and make things pretty like work pretty easily, so that you don't have to like change your KVP and MAS that much. So it's not that big of a deal. But just remember that you can do certain things to change your KVP and MAS if you really need to, if the background is just like, gosh, why is this background so light? Remember that, hey, I can change my MAS if I really need to. If the background is super, super light, remember, turn up your MAS. Okay. And play with it that way. If your KVP is like really weird, if it's not penetrating appropriately on the tooth, change your KVP. If it's something too, well, if you guys probably have digital, but if you don't have digital, and that you have the chair side developer, it could be your developer too. But typically I have found where it's the MAS that's just not exposing it appropriately. So you do have to play with your MAS. But just remember that like you guys have that knowledge base to change your MAS if you need to, or your KVP even on, dental x-rays too. So you shouldn't have to just deal with how your images look. You should be able to, go, okay, I can change my machines and know how they should be working appropriately. All right, any questions on those things? Remember your toes.
I learned a ton. Thank you. That makes a lot more sense. I was online teaching too, like online schooling. So I think when reading it, I just like, I don't get it. I'd walk away like frustrated. So I appreciate it.
I honestly prefer like the bigger x-ray machines over the dental one. I know like you get it better once you practice it more, but it was always so hard to get the bisecting angle and like to be able to get the root and everything of the tooth. And it was just,
Yeah. So you've done dental radiographs on a big machine
yeah.
or no? Okay.
Well, not on a big machine. So in school we have just our own dental x-ray machine.
Okay.
So it's like handheld. It almost looks like an old camera.
Yeah.
And so
I am not a huge fan of the camera ones either. I actually prefer the dental machines themselves. But for a lot of different reasons. It comes to safety is my biggest concern. Because a lot of people don't realize some of the safety features that you probably should have when it comes to those types of things too. So, and what she's talking about too, so like with some of the dental, do some of you guys have the handheld dental x-ray machines? There's a few different ones that you can have, but you will literally have to hold them. It's like there's like ones that look like a gun. There's some that are like a camera versus ones where you actually have it and then you can stand back like 6 feet. That's no. You're the sole
So
person.
we don't have it, but when I was at Purdue, because I did the Purdue distant learning, when I was there for the lab, we had one. And we just because I've never seen one in person before, but that's the only time I've seen it.
Yeah. So when it comes to those where you have to hold it or you have like a trigger finger or anything to that nature, remember when you guys take radiographs, you should have a dosimeter badge and you have your lead that you're wearing and all of that because you're so close to, again, radiation, right? And regardless of the fact that it is giving off what people say is a small dose of radiation, it's still radiation, right? We should be wearing some type of protection. And so you should have, or I should ask, what did you wear for safety?
At NICC, I'm in the same program as Jenna. We just wore everything that we would usually wear for x-ray just because it was regulated by the school for our safety. But I'm not sure other clinics do not wear the whole getup when they do one.
Yeah, well, I'm glad that they have you guys wear everything that you possibly can wear. That's perfect, honestly. And that's what I would always recommend to people is to wear everything that you can. Did you guys have any type of dosimeter on your hand?
not on our hands. So we have our dosimeter badges and we wear those like, even if you're not taking the dental x-ray, you still wear it just to be safe. And obviously if we have our own X-ray room, like we
Okay.
just built it last summer, I think.
Okay.
So even if we're in the X-ray room and behind the wall or whatever, we wear it at all times. They make us, like it's a
That's a thing.
rule for them.
Yeah. They actually do have like ring dosimeter badges. And so it can go right on your finger. And so that way it's as close as possible to get that radiation exposure to you because it's right there. And so that's what we would always recommend is that people, especially for dental films, so that they get that. But I'm glad that they had you at least wearing those dosimeter badges for that too, and that you guys were wearing that protection as well.
And
So-
not that it's perfect, but ours also comes with a like a ring that you put on the end of the camera that's lead lined.
Oh, okay. That's perfect. Yeah. And at least they're, yeah, again, they're shielding there so that it can prevent from as much scatter as possible. So that's good. And another way too that I've seen it is that some people get some of the lead line. There's like, you can get lead. First of all, they have lead lined, like crazy lead lined walls that you can get that are super expensive. But some people also get like kind of what our aprons are made out of, but they have it as almost like a lead line shield, almost wall that you can get for when you're doing dentistry. And so you can get that to kind of protect some of the other people that might be like walking by or that kind of thing. That is helpful. And yes, people are further in distance away, but it can be just at least helpful for when you're taking, radiographs and stuff. You just never know. So, but yeah, I think that's good. I didn't realize that it came with, at least yours came with that little shield. So, very cool. I think that can be kind of hard too, because when you're trying to take a film, at least you have to hold yourself completely still too, versus, having something that I don't think I can hold that completely still trying to take an image. So that probably is very interesting. Plus being at a bisecting, like doing bisecting angle and all of that. So quite interesting. So when we talk about bisecting angle versus doing parallel and all of that, what are our teeth that are parallel versus bisecting angle?
Parallel or is the incisors top and bottom? Are you talking about when you put the plate in parallel?
When we're taking an image, which ones do we take where it's a parallel image versus bisecting angle?
The incisors. For sure.
I know the molars, like especially the 2 and 3 rooted ones, are bisecting. And then I think the canines too.
Okay. So
So the top of the mouth is bisecting. So I just did this for my internship, but I kept laughing because I couldn't say the word bisecting because I was overthinking it. Anyways, I kept saying bi something else and we were all laughing. But it's the top of the mouth, you do the bisecting. And then on the bottom, you run the plate parallel. And then you go, is that right? On the bottom back teeth, molars and stuff, you put the plate in. You like have to push it in there so it's parallel to the inside of the teeth, like the buckle, and then you take the X-ray from the outside.
so you the only ones that are, there are only a few that are parallel. versus all the others that are going to be bisecting angles. So you're right that the whole top ones are bisecting angle. Let me do it. So you're right, when we get to the bottom, guys, yeah, we have to like push that plate in really weird, get to them. And then the rest are going to be bisecting angle on the bottom as well. But the only ones that we actually do that are parallel are those molars on the bottom mandible. So everyone can see my dental chart, right?
Yes.
Okay, perfect. So all of these guys up here are going to be bisecting angle of some form. And then down here, these guys are all going to be bisecting angle of some form. Anyway, so that one, this one might be bisecting angle on some animals, might not. Try to get it in. But these are bisecting angle. Sometimes we can get some of these premolars if possible on some animals, if our tongue will let us. And then these guys are parallel, which when we say parallel, it's somewhat parallel, right? So let's talk about the bisecting angle though, right? So when we put our plate in, we are putting our plate in, if we have, oh gosh, how do I do this without making a fool of myself? What if I find a capybara skull somehow? This shall work. So all right. Let me get back to this. Okay, so if I have my skull here, if I put my plate in and I'm going to do a bisecting angle of, say, my incisors on this guy, I would put my plate in here, right? So it's going to sit right in here. And what I would do is I would take from what my bisecting angle shows me, and I would say that my bisecting angle is showing me that my teeth are at an angle going this way, right? The roots are going this way, right? My plate angle is this way, as you can see. And what we do is we bisect this angle. See how we bisect that? And in this case, we bisect that angle, and we are going to put our beam directly over those teeth. And I'm bisecting this angle all the way down, so I have enough room. Okay. And we're gonna put our beam right over those teeth and bisect that angle all the way down onto those teeth. So, and onto our plate. So that we can get a nice, beautiful image of those teeth. So,
Question, Beth. So the actual beam, the position that you're going to put it as is where the bisecting angle is, right? Like that's the way you're going to like face it on the
Yes.
patient.
yes. So when they talk about, oh, it's at a 45-degree angle or any type of angle, right? I bisected that angle right here. This is 45 degrees right there.
They always have to keep in mind where the plate is and where the root of the tooth is.
Yep. So, so your plate is right here, and then how your root of your teeth are going. So if we were to do our, say we are going to do our canine tooth. Okay, so here's our plate, right? And then we are gonna do our canine tooth, okay? So our canine tooth goes up like so here, right? So I'm just gonna make it nice and long like that, right? So how do we bisect that angle? Actually, I need to fix that angle of that tooth a little bit.
So do you kind of imagine another line? So use a different color, use blue or something.
Yeah.
Okay, so like you got your red line, you got your black line, right? So in between those two, that's where it's bisecting. Is that correct?
Mm-hmm.
Okay, but so you're pretty much just, looking to where it crosses, right? But how do you, but because it's a canine tooth, do you come from the side more or do you come from the front top more? That makes sense.
So if we are gonna bisect this angle here, let's see. I'm going to bisect it here.
Correct. So that's where I was imagining a blue line. But now I'm trying to picture.
And then I'm gonna come back out here so you guys can see
Okay.
it.
I just don't know where you
And so what you're gonna do then in this case is I'm gonna make my plate a little bit longer. So this is where it gets really tricky with your canine tooth because your canine tooth, remember, has a really, really, really long root. And so a lot of people get so wrapped up with getting the whole crown of the tooth in there versus, hey, we got to get the whole root. We can see the crown of the tooth. Who cares about the crown of the tooth? So if you watch Mary Berg's video, she talks about putting your forefinger and your thumb on the nose, like the bridge of the nose of your animal, and your thumb on the side of their like a face as well, kind of like an L. And so if you make an L on their face, and then you put the beam right there, that also helps with making sure that you're going to actually get that whole root in there. So it actually, you're going to bring your beam right down onto this root that way.
Okay, I'll make sure I watch her videos because that'd be a helpful tip.
It's really good. So she does the dog and the cat for you.
She's on your web page actually.
Yeah.
Okay. I just didn't get to it all this week. Okay.
Yeah.
I'll
So
watch
it's
it.
really good because as you see, like if you come over, like if you come from here, you're not going to get the whole root because the whole root comes up to like here. So of course you don't have to bring your whole, you don't have to bring it all the way to the whole animal's face, on top of the face, but you definitely don't want to bring, your beam all the way over here or whatever, but you want to make sure that you bring it as, at the right place. So then one really hard one that I always have are these molars back here. These are to me the hardest ones to get. And she has a really, really great way of doing them. And so the hardest reason for me is because they kind of come at a weird angle and kind of like sneak behind this last molar. So the great way of getting these is that you have your plate in there, right? There are plates in here. And what you have to do is you have to go high and behind the eye, essentially, with your beam. And so you're really coming at a weird angle to get that root or to get those roots of that tooth. So definitely watch the video so that you can see her angles of what she uses to get to that eye. I believe she said it was like 65 degrees or something like that she uses to get those roots of the tooth. Because it's definitely those are tough molars to get.
Yes, thank you. Because I think even I watch senior techs just get so frustrated
They're really tough ones.
because they can't get certain angles and they just want to throw the X-ray machine and tell the vet that's what you get, go away.
Yep.
So
Yes.
no, that'd be good. 'Cause I think they taught me at the clinic for my internship. We came from the side and a high angle, but yeah.
Yes. So knowing kind of some of the positional ways. So 100% if knowing, okay, like we do bisecting angle and that here throughout the mouth, yes, and that these are parallel, but we have transitioned now to doing, more of the angular technique is really, really important because honestly, by sitting here and doing bisecting angle throughout the mouth takes forever, and every animal's anatomy is so different, from a bulldog to, a cocker spaniel to a sight hound or whatever. It's going to be entirely different. So by being able to just say, okay, well, a canine tooth is about a 70-degree angle versus, this tooth is going to be about 45-degree angle and this tooth like 25 degree. It's really, really helpful to be able to learn those those little tricks. So, any questions on that stuff? Now, numbering teeth, when we talk about numbering, we go from our right side being what number scheme in the Trident system?
Right top is 1,
Okay,
left top is 2, left bottom is 3, and right bottom is 4.
awesome.
I literally have to do it on myself to picture it.
Yeah.
You know what I mean?
So you make like a C with your left hand on your face, and you can go 100s, 200s, 300s, and 400s. That's how I have taught it. Now, what about if they are deciduous teeth? So puppies or kitten teeth, how do we number those?
It goes from 5 to 8. So it starts in the same order. With the right upper jaw is 5, left is 6, left lower is 7, and then right lower is 8.
Perfect. Very good. So anyone ever seen the other system that has been used where we will number incisors and see where it might be incisor 1 or incisor 2?
We just learned about it, but I haven't seen anyone use it. So like I mostly just have seen, well, we only use the
Trident.
numbering system.
Okay. So this is where you may see some old, I shouldn't say really old, but older, maybe veterinarians or older technicians use that old system. I learned it when I was in school. We had to learn both. Same ordeal. We were switching over from that system to the Trident system at that time. So it's just good to sort of know in case you do see it. Most people have switched over in that amount of time. It essentially means that this is on your left side, upper first incisor, because it's on your left, right? This is the lower left second incisor. If this is a 3, this is the upper right third incisor. Okay, get a premolar, and that is your first lower premolar on the right. So that's just what they had done previously. Obviously, when we had this numbering scheme, it gave us more utilization of being able to say like, okay, we know if it's a deciduous tooth or, exactly what location it is as well. Like we know that cats are missing certain ones and stuff to that nature. So in this scheme, like we can't tell if they meant like, is that their first one that they know of or their first one that they're supposed to be missing, right? Like, so this just is a little bit more accurate. And that's just small animal, of course, right? So we could go into greater depth about like horses and all of that if they, because oh gosh, like, oh, what do you mean by, the wolf teeth and all of that? So,
I got to see a horse float. It was pretty cool. He
oh,
had me
cool.
teach it before he floated it and after, and it did almost cut my hand on the first before. But that was really cool. I was really glad he let me come and watch for a little bit.
Very cool. Very cool. So speaking of float. So why do we float horses' teeth and not cows?
Is it because horses' teeth continue to grow and cows don't?
I think it's the way they eat because cows turn their bottom jaw and they grind their teeth down and the horses don't. And the vet had shown me the reason why they float is because if you don't, the jaw doesn't line up or something, he said,
Yeah,
while they're eating.
yeah, it won't line up right. Yep. Yeah,
That-
so go ahead.
When it doesn't line up, it causes like abscesses and stuff, right?
Yeah. I mean, and they can definitely like hurt themselves too. So yeah. Yeah, and if you've ever seen a cow like chew, they literally chew like this, right? So they kind of float their own teeth. So yeah, we don't have to do that for them.
Are both the cow and the horse the what's that word? I can never, did Jenna say it? Hypodontic or whatever, where they keep growing all the time?
Orthodontic, yeah.
Yes. Are
Yeah.
cows that way too then, but they pretty much float their own teeth?
Yeah.
Okay.
What about rabbits?
It's the front teeth, isn't it? Where they'll keep growing, but you can buy them chews or you're supposed to file them down.
Yeah.
Is
I've
that
never,
guinea pigs the same way? No?
probably. And rats and yeah. Why are horses' teeth and rats and all of them, why don't they have nice pretty white teeth like we do? And dogs and cats and stuff.
Isn't it like something, I thought there was like a VTNE question or something I saw like
Oh.
about where the enamel grows, like it's on like the aspect of the lingual side. It's not, or it doesn't, there's no enamel on the lingual side or something like that. So
That's
variation.
a VTNE question about something in regard to llamas versus the other one.
Alpaca.
Thank you. Llamas versus alpaca. One of them has it versus the other.
Okay, that must be it then. I'm like, I feel like there was like an enamel question or something like that. There's a VTNE question about
Yeah,
it.
yeah. Yeah. That's like one of those like trivia questions I feel like too. Like which one has it versus the other.
Would it have something to do with their diet, maybe?
Mhm. Yep. What's so different about their diet?
They're herbivores.
Yeah.
So like would it have something to do with the acidic levels, or because like cows' acidic levels are different than humans just because they have to process things different and they have the 4 stomachs and whatever.
Yeah. So what is their acidic level? Is it very acidic?
No, it's on the lower side.
Alkaline.
Yeah.
Yeah.
Yeah, because does it need to be?
No, it wouldn't need to be as acidic because of the plants.
Yeah,
They're
what?
just
Yeah.
processing plants, not meat.
Yeah. I was like, why does ours need to be so acidic?
Well, and ruminants have like fermentation and everything, and they have those microbes to keep alive in
Yeah.
order to.
Yeah, if they had all that acid in there, oh gosh. Poor things would just die horribly, right? So why do we have to have so much acid in our gut? I say gut as a generalized term.
Meats maybe have like stronger bonds, I guess, that we have to put like hydrogen in there and break apart, I guess.
Okay. Yeah, to break things apart, digestion, good. What else?
I could be totally off, but like when I think of digestion in a cow, like they have a stomach to grind things up, and like they have all these extra stomachs that do these extra things, but we don't. We only have the one. Like we don't have a grinding stomach. So does it have something to do with helping break? Well, I guess you said break things down, but like since we only have the one stomach, we have to have more acid to digest.
Yeah, definitely. What else? I mean, we're eating essentially some pretty crazy things, right? Or carnivores are eating pretty crazy things. What can they contain?
Bacteria.
Yeah, some pretty crazy pathogens, right?
So
Like-
the acid helps kill them.
Yeah. So yes, we as civilized human beings now are cooking our meat, but before we did not cook our meat, right? And even if we cook our meat, sometimes it still doesn't always kill pathogens because we get sick once in a while from eating some crazy stuff or whatever. And animals that are carnivores don't cook their meat, right? I mean, outdoor cats, you don't see them cooking up their kill that they get. So, yeah, they have to have a pretty strong gut in order to help them to be able to truly digest what they have eaten as a carnivore, right? So in ruminants, they don't have to necessarily do that because they're going to eat stuff that is pretty pathogen free for the most part. They're going to ferment all of that stuff, and when they actually discard all of that stuff, it turns into a manure and is going to be reused again for good purpose, right? So it's actually a good thing. Wonderful. So when we're talking about teeth wise, right? So we're talking about, again, like the coloring of their teeth and all of that. Their diet has a lot to do with the coloring of their teeth. And when we look at their teeth color and we see that like maybe a horse teeth are like a dark brown or black or whatever, that doesn't mean that like they have bad teeth or anything. That just means that they have a very full and rich diet, right? So if we maybe see that, you know, their teeth are yellow and stuff, that's totally fine. Same thing with rabbits or a rat or anything. And the more that you see them like grazing and stuff, you might even notice that they'll have darker and darker teeth.
Beth, is it not? I don't know if it's true. Is it because they don't have the dentin, or is it just I'm making that up?
No, I think it's just due to the richness of their diet. Is my interpretation of it. Awesome. All right. Anybody have any exotics that I say exotics, but you could have horses or anything too. Well, actually I should say exotics because horses you would have to flip their teeth. But any exotics that you would have to monitor teeth, whether it's rabbits, rats, I guess maybe chinchilla, guinea pig, that type of thing at home.
I have a rabbit.
Oh, you have a rabbit. I have a rabbit too.
Yeah.
Well, I should say my daughter has a rabbit. So, do you do anything in particular for your rabbit teeth?
She has willow toys, like willow
Okay.
shoe toys, sticks, that kind of thing. Hay, definitely, because that helps
Yeah.
wear it down. I give her Timothy treats to help wear it down as
Yes.
well.
Yes.
But
Yes.
she also likes to chew on her wooden castle that I
Yep.
have, so that helps.
Very good. So yes, these animals are a big portion of their life. When we talk about dogs and cats, especially, actually cats do enjoy chewing, by the way. A lot of them do enjoy chewing. Is but also very much exotics. A big part of their enrichment is chewing. And so giving them stuff to chew on is really, really important to help them so that you actually don't have to have their teeth trimmed. So like my rats that I had previously never had their teeth trimmed. My rabbit never had his teeth trimmed. So yeah, giving them toys to chew on. I mean, it can get expensive because they literally chew through everything. But yeah, getting them a ton of stuff. So yeah, that's awesome. Yeah, he goes through all his stuff. And also like fresh veggies and stuff are really good for them to chew up their fresh veggies, and they shouldn't actually have that many pellets. Honestly, pellets are very, very rich in sugars and all of that. So giving them regular veggies every day as part of their diet is really, really good for them. Awesome. Okay. Any other questions you guys have? Great.
Nope. What do you want us to study for next week so we're all on the same page?
All right. I got most of you guys all on the same page as of last week, and I'm going to get the rest of you guys this week is based on a rotation. So this week we are on, let me just make sure. We are on, let me make sure we're logged in. I think it's supposed to be pharmacology. Yeah, it's pharmacology. And yep, pharmacology. So the rest of you guys, I will make sure that you guys are all linked up to the same weeks again. So you're on pharmacology, and then we'll all be on the same page. I appreciate you guys letting me know about that. And then yeah, the week after that will be anesthesia, surgery, et cetera, et cetera. So.
All right, pharmacology sucks, but okay.
You'll make it.
Hard to find.
There's so much in pharmacology. That's why.
Getting better, but
Just practice, practice, practice. Lots of it. There's just a lot of things in pharmacology. So. All right. You guys reach out if you need any help or need anything. And we'll see you next week.
Thank you.
Of course.
Thank you. Have a
Take
good
care,
weekend.
guys.
You too.
Bye, guys.
Bye-bye.